All right, well, thanks. Welcome, everybody. I hope this is a great session for you. We're going to look at some things from different perspectives, more sort of from the business aspect, but also I'm going to share a lot from the healthcare providers aspect and some of the real challenges that literally all hospitals and healthcare organizations are facing right now. So we'll start off with this slide. So this is ASHRM's Enterprise Risk Management domains. And this really is a big focus on patient satisfaction that really has become an enterprise risk. So in terms of looking at the domains that are impacted by patient stat, the operational domain, which essentially looks at it from a system standpoint, financially is really big right now. I think everyone's aware of value-based purchasing and the hundreds of thousands, if not millions, that are on the table for individual hospitals based upon the reporting of patient satisfaction on the patients that are admitted. There's also the strategic, because HCAHPS in patient satisfaction is now publicly reported. It's very easy for someone to go online, take a look, and see how a particular hospital does compared to other ones, as well as the fact that I find that a lot of people now are not only looking at satisfaction scores and reports, but also we had a physician actually that had a bad score on Yelp. So this has just really become a mainstream thing. There's certainly the staff element in healthcare provider satisfaction. And of course, what we really want to talk about also today is the legal regulatory part. And the bottom line is that unhappy patients sue. So I'm giving this presentation today from Hackensack University Medical Center. Hackensack, where I work, is just outside New York City, but in comparison to the 184 hospitals in New York, where our quality rankings, recently used News and World Report, had us at #3 and #1 in the state itself. We're a magnet-recognized hospital in that the nurses here, this is actually one of two hospitals that were the first magnet-designated nursing hospitals. So we really take pride in the quality and, but are continually looking to improve. My role here is I'm the vice chairman of the emergency department. A busy emergency department sees over 111,000 patients a year. But perhaps I'm even the most proud about is I came over here a few years ago to build and found a residency program. And I'm actually literally interviewing today medical students for our residency program. And we have 2 classes, and in July, when we have a full 36 residents, we'll be the largest in the state out of the 10 programs. And as I shared with the students I just met here about an hour ago, on the right-hand side, this is our motto, and this is what we're proud of, not only of the quality and focus of the institution, but the way that we're training physicians of the future. So this motto here is something I came up with that I feel we're doing. We're improving the patient experience one resident at a time. So for us, it's the new way of training, the new focus that's patient-centered, and collaborative efforts to really do what's really best for patients. We obviously focus a lot on that. And, it's really a hot topic. It's been something I'm very passionate about for several reasons, which I'll share with you. But I've had the opportunity. What's interesting about speaking about this is that there's such varied organizations where this is so important, not only to their mission, as I mentioned, as the ASHRM slide showed, but healthcare executives. ACEP is our American College of Emergency Physicians. There's groups out there that are doing specific patient experience conferences and focuses, as I've spoken on, and even going into hospitals and a lot of places to sort of rally the troops to improve upon their efforts. Most recently, I spoke at our American College of Emergency Physicians, which has over 6,000 emergency docs, and was able to provide a communication training workshop. Now, what's occurring now in emergency medicine is they're realizing that their job security is in a large part dependent upon how well they communicate and the actual scores they get from communication. So a very popular topic, we put this training workshop together, but some of the talks I gave were focusing on liability, because there is certainly the connection that people realize that unhappy patients sue and happy patients do not necessarily sue, but then also about how this applies to job security overall. And part of the frustrations, part of the tough thing is that there's really not great training, I hate to say, for both nurses and doctors in communication training. And part of the problem is that some of the programs we're essentially trying to take some business models of customer service and apply it to the healthcare world. But these models and programs are not always designed by clinicians, and usually they're not. And it's sort of a top-down approach where you have the C-suite sort of implementing these ideas, but it's not really reaching the people on the front line. And so the traditional style of lecturing, although it's nice to do it in a format like this where we can all share things at our desktop, having just a lecture doesn't mean that people will actually show up, and it's hard to really ensure that the learning is occurring at the bedside. And some of the tips and tricks with acronyms, I think, don't really resonate with a lot of physicians who are essentially looking at changing their practice. And the bottom line when it comes to healthcare industry is outcomes and how it affects us financially. So I put together, as part of our National Council of Residency Directors, I put together this task force. And what we're doing is that we're trying to provide better information to our future doctors, and we're also trying to provide tools so that they can better evaluate themselves and evaluate them to get them prepared for entering the real world, so to speak. And this is something that we're doing with many directors throughout the country, so this is hopefully going to help change things in terms of the future of how we prepare doctors for practice. So today, it's going to be simple. We're going to focus on three objectives here. We're going to first focus on this major idea of liability and the risk from being poor communicators. Then we'll touch base, do a little overview on the financial perspective and what's currently happening today with value-based purchasing, which came off of the Affordable Care Act. And then we'll look at some best practices and some things that we try to put together to create change and really make a difference here. So number one, let's talk about liability. So physicians and people in the healthcare industry know that they're practicing in a risky job. Looking at this release from New England Journal in 2011, those docs that are working in a high-risk specialty, they know that by overwhelmingly, almost guaranteed, they're going to get sued at some point of their life, which means, unfortunately, multiple lawsuits. Even those in very low-risk specialties, 3 out of 4 are likely to be sued. So this is something that's on our mind. This is a constant concern and threat and something that's part of our natural practice. So we want to look at how in the world can we prevent that from happening? Well, taking a look at some of the literature here, we're able to see a correlation between the amount of complaints that patients have and risk management episodes. This particular study found that if a physician was receiving 2 or more complaints in 1 quarter, then that increased their risk of risk management episodes by 4 times. So eliminating complaints, getting people happy, seems to be one of the keys of decreasing risk management risk. And even going back, this was an interesting study out of JAMA that looked at specific training of physicians in Canada. And one thing that they do is they look at their these communication scores as part of their board examinations. And then they went back and they found out that of the physicians with complaints, they could take it all the way back to before they started practicing and able to predict those with poor scores and poor communication were more likely to get complaints. And it kind of leads to this bottom line quote. Really, the most common cause of malpractice suits is failed communication with patients and their family. So the most common cause, malpractice suits, failed communication with patients and their families. So now we're in this era where anyone can hop online, go to Medicare.gov, plug in a few hospitals. This was from a talk I gave in Seattle, and literally what I did is I put in the zip code, and it pulled up the 3 closest hospitals. And it gave comparisons on how well the HCAHPS scores were and specific measures that were seen as quality indicators of how good a hospital is. This is something I really want to bring to everyone's attention if you're not familiar with it. So this is the liability report that was just released in combination with Aon Risk Solutions and Ashram. And this was one of the first times where we can tangibly see the effect of patient satisfaction and lawsuits. And this is something we inherently know about. You know, it does make sense that communication and poor communication and the frustrations and cover-ups that go with it tend to stir the pot when it comes to the potential of lawsuits. And you know, I learned this lesson early on because, frankly, when I was first practicing out of residency, I remember working with someone who really, frankly, wasn't the strongest doctor and not necessarily the most skilled or smartest doctor. And in talking to her, she'd been practicing almost 20 years. And, you know, here I'm a resident right out of residency, and I was, you know, scared if I'm going to get a lawsuit and just kind of naturally worried about that. And I remember her saying, you know, I've never been sued. And my first reaction was like, really? And, you know, not to, you know, talk too badly about her, but what I realized from that is that she was one of the nicest doctors that I came across. And yes, she was making mistakes, but she really was able to display this level of empathy that despite the mistakes, somehow, some way, she did not fall into the 99% that would probably be sued at that point in her career, and she just simply wasn't sued. So, but let's tie this to financial. What does this mean for us now to improve our patient satisfaction scores? So the HCAHPS measure, what this is able to show us is that if we increased our HCAHPS at the top box that they use, 9 and 10, if we just increased it 20%, it actually found that in all these hospitals, well over, I think it was 100 plus hospitals here, that if you increased by 20%, it'll decrease your frequency by 1 claim per 100 beds. So in the average hospital, that ends up being about $170,000 per 100 beds. So at a hospital like this, that would be about $1.3 million, and probably higher because New Jersey's has a higher risk overall. In the same study, it was essentially looking at this idea, and this is sort of where it came from. For those with the high scores, jumping down at the bottom here, that got 9s and 10s, the big difference in terms of your claims per 100 beds. So if you only had 50% high scores, you had about 2.6 claims per 100 bed, whereas if you increased it to 80%, your claims dropped all the way down to 1.1. So significant dollars, you know, million plus depending on your size of your hospital, but I think this is getting people's attention. So it led to this quote here, that results indicate that risk managers can use patient satisfaction surveys, scores as a marker for detecting and remediating areas in need of improvement. There's a couple links here that sort of cite this report, and we're certainly happy to share these with you afterwards as well. So we know this now in healthcare, the financial impact, whether it's directly through HCAHPS or indirectly through savings and decreasing risk from having better overall satisfaction and a better perception of experience for patients. And this is interesting here. So this actually looked at CEOs' compensation, and they were able to find out that the only things that were associated with the CEOs at this just under 2,700 hospitals was technology and patient satisfaction. So when I'm speaking to the docs and the nurses, you know, I can reference that in terms of saying this is not going away, this importance is only increasing. And it's reached this point. So you may not be familiar with this, but what this is actually a report of patient satisfaction. So the doctors in the green are the high performers, the ones in the yellow are in the middle, and the ones in the red are the low performers. And this is, on the far right, this is a national percentile. So at the top is 99 percentile comparison, and at the bottom is a 1 percentile. Well, if we have a system now where we're losing a lot of money from poor scores and our CEOs are getting paid less, then you better believe that the CEOs and other people are looking hard at the patients in the red. So the conversations that are occurring in hospitals are such that directors and chairmen are being asked, well, what are you doing with the people in the red? What's your plan? Why are they still here? They're pulling us down, this and that. So this has really become an emphasis on performance evaluation for physicians and nurses now. And it's frustrating because, like I said, this training, this has not been an emphasis when a lot of people entered medical school and nursing school, and nor has it really been a measure of job performance. So this is kind of rapidly picked up and become an increased emphasis without the previous training. There is a liability risk here, but then are the doctors and nurses really getting good training, and are they getting good feedback? If they want to improve, do they know how to improve? Do they have the tools to improve? Do they have the support to improve? So we're in this sort of frustrating position right now, I think, for a lot of healthcare providers. So let's take a moment and just take a little overview of the financial perspective here. And we'll start off with some recent history. So in March 3rd, 2010, the Affordable Care Act went into effect, and essentially this moved some reimbursement from the fee-for-service towards the value and the value-based purchasing. Then in October 2012, Medicare began rewarding hospitals that provided the high-quality care through its value-based purchasing program. And as they did then and as they're doing now, they're withholding a portion of the hospital's DRG payment and rewarding those with highest scores. And the way that they do this is they split up this amount. And so as you can see, it's increasing a 0.25% per year from looking initially at 1% and moving up to 2%. So they're withholding this large amount, and they're distributing it based upon specific indicators. A major indicator that's worth 1/3 of the total pie is the patient experience of care, which you see here to the right, and that's broken down. It's basically all that is the HCAHPS surveys. And the 8 things mentioned here are the things that are questioned in the HCAHPS surveys, and that total score makes up a good part of the pie. Also, some other things, they look at outcomes, efficiencies, and clinical process. So those are the domains that encompass the value-based purchasing program. And this sort of shows it again, kind of looking a little more at the specifics of patient experience in HCAHPS. So when you break that down, you're looking at a fair amount of money that's being withheld per CMS patient that's discharged. And again, depending on the size of the hospital, looking at over $100 per patient that's being held for every patient discharge, it's very significant. But when you look at the categories that had, if I just jump back for a second here, HCAHPS is broken down into these 8 things here. But if you look at the categories that had the largest weight towards the overall score, you're really looking at communication. Specifically, number 1 was nursing communication, number 2 is physician communication. So if there's a way we can tackle that, then hopefully we can build something that can improve HCAHPS, decrease risk, and get some better reimbursement. So that's the challenge here. We looked at the obstacles, and this is what we thought would be a good solution, and at least sort of the dream scenario. Now, if we can build something that's systematic, that's evidence-based, that an entire organization can do, scalable, reproducible, that's different than just the traditional lecture, go to the lecture. Before we built the program that I'll refer to, I remember going to a lecture that was designed to improve communication, and it was in the hospital, and they were trying to improve the physician scores. Well, as it turns out, I was the only physician in the room. There were several nurses in the room and several other ancillary staff, but we're not exactly meeting our goal of improvement when you only had 1 doc that actually showed up for the lecture. But besides that, we want to be able to reach people, be able to deliver it in a way so that they're focused. I personally feel that video communication would be strong, showing the wrong way to do something followed by the right way, and having some teaching in between, able to provide some performance to that, have an objective action plan they can work on, and ultimately making it focused on the outcome. So a program we put together here is called the Patient SET program, which stands for Satisfaction Every Time. And our goal is to provide this consistency and provide some tools that physicians and nurses can use to improve their communication. And we put this together from the design of coming up with a core list that was sort of based on the evidence the patients really say they want out of their experience, and then putting together this multimedia education through video, and then following up and seeing if actually we're putting what we learn into practice. So here's the list. So we actually break it down, and we teach and we observe to see how are doctors establishing a connection. You know, frequently doctors and nurses are running around real busy, but what are they really doing in the moment when they first make a first impression? You know, are they even smiling and making eye contact? How are they introducing themselves? When there's long waits involved, is someone taking responsibility for those waits to acknowledge them and apologize? Are they doing additional things, non-medical gesture, just to show they care? And are they estimating time, giving time estimates? So we looked at these different stages and actually teach these things as best practices. So here's the fun part, the fun but strenuous part. This took a couple years to put together. So I live in New York City and able to take advantage of the wonderful actors working and non-working, or partially working even, and put a casting call out. And so we created, first of all, some scenes based upon the hospital scenarios, and put a casting call out, got the team together, hired a professional videographer, and filmed this in multiple sessions. So this is part of some pictures from some of our filming sessions that we did for these videos. And then we established this education. So the education is available for physicians, mid-level providers. It's available for nurses, and then there's also a course that's available for the additional healthcare workers. Those that take it end up getting the CME for the docs, the continuing education for the nurses. And then after the education, what we do, we actually observe them at the bedside. So we find out, to be able to give them objective measures, we find out what they're really doing. So this way, when we follow up, we're able to give people examples of what they're doing well and not doing so well. Here's an example of the nursing training. So the nice thing about this is what it actually does is go through all these HCAHPS scenarios and hits them right on the head, showing the poor practice and showing the best practice and discussing the HCAHPS. So nurses are very specifically focused on what the questions are going to be. For the physicians, the approach we take is actually focusing on the most common malpractice risk scenarios to show them how the poor communication leads to those errors. And that grabs the attention of the docs, you know, done in a way that's sort of real to them and scenarios they're very familiar with. For the other employees, I think we take a lot of the customer service principles. How well are they answering the phone? You know, that's a frustration that a lot of us have even within the hospital. If you call down and someone kind of just briefly answers the phone and puts you on hold, and how good's the communication and customer service within the hospital, and certainly those impressions are very important when patients enter any healthcare setting. How are they greeted? We feel that's just as important as any doctor or nurse's training. So then afterwards, we get these observations, and we're able to get some objective information as to how well people are actually doing this. That allows us to do some comparisons compared to other doctors. So this is when you really are able to affect change, because this is what physicians relate to, is objective measurements about themselves in comparison to their group. We're able to drill down to find out where they are, how well they're doing in specific things. So therefore, I might find out, well, hey, this is a doctor that never smiles and makes eye contact, and that's pretty poor compared to his peers. So that helps to grab their attention. This is a neat slide here. So what this is that the red represents patient satisfaction scores, in particular Press Ganey. So the box on the left, the group on the left, are the low red, are those that did not do that well in patient satisfaction. So what we did is we took these all these observations from these doctors and mid-level providers, and 220 observations. We basically said, hey, we're going to watch you we're going to watch you for your bedside skills and communication skills. Well, the docs that don't score that well on satisfaction scores, not surprisingly, are also the ones that didn't do a lot of those basic things on the patient set list, even in their best case scenario. But on the other hand, the docs that had high Press-Ganey satisfaction scores on the far right, where it's 85% here, those are the ones that actually did follow the principles. So I'm actually working on making this into publication right now, because I thought this was some pretty neat results. But what was also interesting is that if you look here, the 45% on the left was the group that had low scores. The one in the middle, 85, was the one with the high scores. But the one on the far right was actually the repeat. So this was 6 months after training those that were low and putting them through, getting them through the training and then re-observing them. They were approaching and getting a little closer to the ones that were high. So basically what this means in a nutshell is that we all know our interaction with physicians, and you have those that are engaging with great interpersonal skills and those that hopefully are smart physicians and good at what they do, but just totally lack the bedside. So what this is suggesting is that perhaps we're able to do some training and teach these physicians that lack those natural skills and bring them up to speed more with those that are naturally better at it. This would be a big deal if we can continue to show this. All right, so that was with the doctors. Now with the nurses, we have a dashboard where the nurses were able to look at all the different units, see if the managers and the nursing floors are actually really doing their job and trying to evaluate people and try to provide some information for them. We can break it down by nurses in particular to see how many observations they've done. We can also find out how they're doing overall on the communication list and how they're doing compared to their peers. That gives us some specific things to speak towards. So that kind of brings us back to this, being something that we can do at a large health hospital setting, that's led by doctors and nurses in terms of the video-specific examples that they're familiar with, getting some assessment about how well they do it with an individual plan, and then focusing on the outcomes. We have some pretty impressive outcomes. This is done in an emergency department, and as you look at the red arrows, this is in a focus to improve the physician and mid-level provider in terms of their patient satisfaction scores. Is a pretty dramatic improvement when they went through this process. And, we know it's important. If we really want to increase HCAHPS, let's go after the thing that's the biggest bang for the buck. And that's where this is information here. If you go online on hcapsonline.org, this is straight from CMS. That was published April 17th, that should be 2014. But this is after 3.1 million surveys. And so what they found was that of their elements of the scoring of HCAHPS, the thing that correlated the most with the overall score was communication with nurses. So if your strategy to improve the patient experience or improve HCAHPS to get back some of the money that's being lost or decrease lawsuits, if your strategy doesn't include a specific training for communication with nurses, then according to this, I think you could be missing the boat. So we did this focus on the group where we went hard with 18 nursing units. We put them all through the communication patient set program, and we were able to find, and we looked not only at their specific communication scores, but then we looked at the overall HCAHPS scores. And it was really interesting because the nursing communication scores rose from the 41st to the 73rd percentile, as did the overall scores from the 51st to the 74th. Then that was sustained 6 months later. In fact, it actually climbed. So the nursing went from what was originally the 41st, they're all the way up to the 84th. And overall, this took them to the 78th percentile for this group's overall HCAHPS, which again, not only are we talking about a significant improvement in terms of the reimbursement from CMS, but also, as we remember, talking about the risk, the decreased risk here. If we're going from original HCAHPS scores, from say 51st percentile up to the 78th, you're looking at well over, it's what, 26% increase. So you're looking at potentially having that well over $1 million gain from the decreased lawsuits. And that's what this is speaking towards. So again, this report is speaking towards if you can increase your HCAHPS scores, then you can decrease your lawsuits. And they claim this is by 1 claim per 100 beds, which has a pretty significant financial impact. So wanted to go through this, give a little overview, but I really wanted to save a lot of time for any specific questions. And for some reason, if we can't answer them now, we're happy to answer them offline or in follow-up. I have some information here. This is actually my website, as well as Twitter and email if you want to contact me directly. But there's some videos and some information on the website itself.